be on the phone who are not yet online or who are not going to be online because they're calling in from an airport or a car or walking away from a meeting. So we'll be getting underway right about now. We do have for today a two-part agenda. We will be having our research in progress presentation first by the New Hampshire Public Health PBRN. And then we're going to be taking a very short break for a couple of updates from the coordinating center related to randomized control trials and translational opportunities coming down the pike. And then the second half of the meeting will be with some of our grantees, some of our PHSSR grantees, talking about recent experiences in dissemination and implementation science, particularly focusing on recent conferences, including the DNI conference co-hosted by the National Institutes of Health and Academy Health just a couple of weeks ago in Bethesda. So we'll be getting through all of that today. We've got a lot of material to cover, so I see no reason not to go ahead and get started, handing things off to our team from New Hampshire, who will be talking about funding sources, infrastructure, and public health service delivery in New Hampshire. Leah?
Yes, thank you. So I just want to make sure that I know, do I have control of this, or am I telling you when to change, or?
You have control of it, Leah. If you see on the button, there you go.
Okay, yeah, great. Okay, thanks. How savvy. So good afternoon, everybody. My name is Leila Fave, and I work at the Community Health Institute in New Hampshire. And we have I'll just get right to my next slide is about our partners. Our project was to explore funding sources, infrastructure, and public health service delivery in New Hampshire. So, trying to do this on the wrong thing. There, okay, thanks, sorry. The New Hampshire Institute for Health Policy and Practice at the University of New Hampshire and the New Hampshire Division of Public Health Services partnered with us, with Community Health Institute, for this study, and we have benefited from the technical assistance of Patrick Burnett, who's going to present his analysis at this piece, and Danielle Varda, who supported us with some of the network analysis process. So the purpose of our study was to better understand the funding sources and allocations for key public health focus area, which was tobacco prevention and cessation. Also, to understand better how to collect data that can be used to do similar financial assessments for other public health issues and services, and to understand how funding and allocation for services relate to connectivity among partner members of local public health systems. So that's where we started, and as we got into the initial part of our research, we discovered that it made much more sense in the context of the way that the system works in New Hampshire, to not limit it to tobacco prevention and cessation, but to actually broaden our scope to incorporate all public health services provided within the individual public health networks. So just to set the context, New Hampshire is a small state with about a population of about 1.3 million. We are the live free or die state. We have very little formal infrastructure. We have no income tax, and we have no sales tax. So we basically have no real tax base, which translates into not a lot of services. The state has been working in the past few years toward transforming the and building some kind of infrastructure at the regional level. So the existing public health infrastructure in New Hampshire is at the various levels. At the local level, there are 234 cities and towns, and each town is required to have a health officer by statute. However, there's no parameters around the health officer experience or education or certification or even hours. It's some of them are part-time, some of them are volunteer. We have 2 comprehensive municipal health departments at the local level. At the regional level, as I mentioned, we've been involved in a regionalization process. Right now, there are 13 regional public health networks, and we have met with what the group that we've been working with are lead organizations in 4 specific regional public health networks. There are no county health. Hello? There are no county health departments, but because of the nature of, because of that, there are strong community level informal public-private partnerships. At the state level, we do have the Division of Public Health Services, and as I mentioned, the foundational work starting about 5 years ago, there's been a lot of work that's been done in the state to establish and build a regional approach to public health. So in 2013, and we did a whole regional public health capacity assessment. We looked at governance across each of the regions and financial resources and how monies come in and go out. And from that informed the development of the network, the regional public health system that is in place right now, which is actually newly, really in an active state of evolution. Right now, each of the 13 regions are working to develop leadership councils within each regional network. Last year, we did a network assessment with the State Department of Public Health Services, working with the Coordinated Chronic Disease Prevention Program, and we conducted a network analysis using the partner tool, and we were identifying the lay of the land around which organizations at each regional level worked on which 3 top state priorities, which were tobacco prevention and cessation, obesity prevention, and chronic disease screening and management. And that's where the data comes from for our network analysis. So we identified and engaged 4 different public health regions and the lead agencies within each region. We tried to spread them out across really very different kinds of structures and governance models and geography. So we have the 4, and I'm going to talk about each one of those a little bit later. But within those 4, out of the 1.3 million population, we are actually covering about 1/3 of the total population of New York. So our study design was kind of a parallel process, which was to take findings from a financial assessment and findings from the partner social network analysis assessment and look at them together to identify the connectivity and how connectivity might impact how funding and allocation services relate to connectivity among partner members of a network. For the financial assessment piece, we started with a qualitative data collection where we developed a guide, a schedule of questions, and interviewed key members of those lead public health entities in each one of those regions. And from those interviews, that informed the development of a financial assessment tool that would allow us to capture information that was not consistent across the four partners. And from there, we then populated the financial tool. And then for the, as I mentioned, for the collaboration assessment, we conducted the partner survey in 2013. We initially were looking at tobacco prevention services, but we ended up expanding our scope. And we looked at network measures of density, centrality, and trust, and we also looked at collaboration levels among partners in the network. And Patrick Burnett is going to talk later about the analysis that he did putting the two data sets together. So it was a mixed method study. The qualitative aspect was the qualitative interviews, and we asked about framework, we asked about governance, we asked about services and funding sources and flows of funding. We analyzed the transcripts to identify major themes, and we used the information from the interviews and the experience from the interviews to help us build the data collection tool that we ultimately used to collect the data. And through our qualitative findings, although we started, as I said, with looking at the tobacco, we identified a whole range of public health issues that the networks are working on, and they track pretty consistently with the state's public health priorities, and in fact, some of them are funded by the state, so that would make sense, but not all of them are. But they do track pretty consistently with the state's priorities. We also mapped the types of services that were mentioned against the essential services. And I want to point out that we weren't asking specifically for any of these participants to talk about all their services. So this isn't an exclusive list, but when we map this against the essential services, we see that all the services are essentially tapped with some of these types of services that are provided. And the one on this table that doesn't show is the Essential Service 10, which is the research, but we know that they participate in research because they were participating in the study, even though the data that we used was for fiscal year 2013. And we did expect to see some, like emergency preparedness and health education, but there were others that we were surprised by. We didn't expect to see providing services such as insurance enrollment or clinical integration or care transition. So there's a range of services that are being provided by these, with the exception of the one local public health department, by these informal public health networks that are evolving. All of them identified health education as one of their key services. So the quantitative methods include collecting detailed financial information from each site, and we looked at the funding sources, types of funding sources, the amount of funding, and the services that were delivered. And we also have quantitative data from the partner survey, which included, as I mentioned, the network metrics as well as the levels of collaboration. So the process that we went through for standardizing the template for the data collection was that this was done mostly by Stacy and Joe at the University of New Hampshire. They created a master spreadsheet by initially asking each of the site for their budget, including all grants, contracts, donations, municipal funding, asking for staffing counts, positions, and FTEs, And they created a master spreadsheet for each site where the y-axis lists all funding uses and the x-axis lists all public health topic areas that they were funded for. Then for the second step, they populated the master spreadsheet. And it actually took some time to populate because the budget information and the data came in so many different formats from various tracking systems and different, there was different issues that they were trying to reconcile around fiscal years versus calendar years versus program years, et cetera. So there was a job to get to the standard template. So step 3 was they organized each budget, organizing and group funding sources and FTEs, and color coordinated each funding item, and developed some standard funding uses groups, and developed standard personnel FTE groups, and we're going to look at those momentarily. And then step 4 was actually they created a condensed spreadsheet which allows them to actually compare fairly across the sites against each other, regardless of the fact that they each had different budget collecting and reporting structures. So they developed that standard template, and in terms of the categories that they identified for spending areas, they identified these on the left, basically, pretty standard spending areas. And for funding areas, they identified federal, state, private, healthcare, business. So when they put it all together, what they found was that across, really quite a bit of variation across each one of the regions. And you can see specifically the spread, particularly in the operations row down toward the bottom of the top table, where, it ranges from 3% of the budget for the Manchester Health Department, which is the local health department, up to 12% at one of the other 12% of their budget at one of the other Lakes regions. And also looking at the funds spent on contractors, you can see that in one of the regions it was as high as almost 30% of their funding, and as low as 0.2 in another one of them. For FTEs, the groups that we classified were leadership, program staff, and administrative staff. In terms of funding sources, again, there's quite a bit of variation, and one of the things that's interesting here is that, and I'll point it out because I'm going to look in a little more depth at each one of the regions, but you'll see that each region, actually the majority of funding for each region, source of it is different, which was surprising. So now I'm going to dive into looking a little bit more specifically at the regions. We used the partner tool, which is the web-based social network analysis tool, and again, remember we collected data on partners working on all three of the priority areas, tobacco, obesity, and chronic conditions. So, and the network measures that we looked at were density, degree of centralization, and trust. The density measure indicates the number of relationships or the number of ties for each relationship between each organization that was identified. There's a tie there, and if all of each organization was connected to every other organization, it would look like a big block square, but that would be 100% density. And then the degree of centralization has to do with the measure of how well the amount of organizations within a network that are well connected, that have the most connections. So in a network that has a high degree of centralization or a high centralization score, that would indicate that one or a small group of organizations are really at the core and highly connected, as opposed to much lower or fewer connections on the outside of that core. And where there is a lower centralization score, it indicates that there's more spread out connections across partners. And then the third measure here is trust, which is a measure, it's an aggregate measure. And each, in the survey, each partner is asked about the other organizations that they work with around how reliable they are, how much in support of the network mission or purpose the organization is, and how open to discussion, negotiation, or how easy they work with. So, I just lost my screen. Can you see it?
I can advance for you if you would like. It might be that your computer fell asleep. Try moving your mouse around.
No, not. Okay. Well.
Do you have the slides with you? And
yes,
I can just.
I do. Yep.
That's great.
Yep.
Just let me know when you want me to advance.
Okay. So we'll talk about each one of the regions and look at these characteristics and how they're similar and different from each other. And the first one is the Greater Monadnock Region Public Health Network, so you can go to that. And you've already seen, so I've brought in the individual data from those larger tables earlier, but so I've included them at each one of these regional levels. You've already seen the total FTEs, for example. This network map and the scores reflect the whole network and includes the partner organizations across, there it is, thanks, across all three of the priority areas. And in Monadnock, which is a kind of an isolated region down in the southwest corner of the state, this public health region covers 32 municipalities. It's got a budget of just under $500,000, and there are 9 organizations that generally are involved in providing services around these public health issues. In this slide, the arrow is pointing to the organization that's the lead public health entity in the region, and that organization sits within the hospital. It is part of the community department of the hospital, and so that's where you can see that they're very connected across to the other partners. But in this map, you can also see that several of the other partners are also well connected. So the centralization score is not high and not low, but that's because even though that organization is highly connected and fairly central, other organizations are also highly connected. And this region has been working on a pretty rigorous initiative to become the healthiest community in the U.S. by 2020. And they do have their level of trust that came out of this survey reflects their ability to collaborate with each other. They're very they are very organized and together and actually have implemented a collective impact approach to the work that they're doing out there. This slide shows that the majority of their funding comes from a private foundation, which is the foundation that's connected with the hospital. And you can see that they only have 3 sources of funding that they reported. The 3 maps here show the difference between when we pulled out for what the organizations that are part of the network working on obesity versus tobacco versus chronic conditions, and you can see really how different the structures are across that region. But within every one of these, that organization is really fairly embedded in the structure for every one of those networks. The next one that I'm going to talk about is the Manchester Health Department, and again, this is the municipal health department for the largest city in New Hampshire, although the health department does serve 8 municipalities, so the city and then 7 surrounding towns. It serves a population of 180,000 with a $3 million budget, and the local health department is that green node at the center, but when it comes to looking across all 3 of the public health priority areas that the survey identified, that there's a lot of connection across the state, across the city and the region as well. Although they have a higher level of centralization than Monadnock region, they also have a lower level of trust, which is actually consistent with some theory that says that with higher levels of formal linkages, there are lower levels of trust, and with fewer formal linkages, like specific contracts or law, with fewer, the trust level rises. So that's this is comparison to Monadnock kind of illustrates that, provides some evidence for that theory. Their greatest funding source is municipal funding, and you can see here in this set of slides that they're that yellow node, and they are very central to most, although you can see from obesity that there are organizations that are working on it that they're not connected to. The third is the North Country Regional Public Health Network, and that's the northern. It's the largest geographical area. They have a large number of funding sources. They have a large geographic area, 37 towns that they're working with, and 24, the largest group of organizations in their network, and they are very much central to this network. They're the turquoise node in this map with a 74% degree centralization and a fairly high level of trust at 76.8%. They are the organization that is the lead there is a very well-established consortium that is the North Country Health Consortium that is involved in really a lot of grant writing and flow of monies out through the consortium to the organizations in the region. And again, on the maps, you can see that they are very central in each one of these priority areas, and their as a rural network, the majority of their funding comes from federal sources. And the last one is the Winnipesaukee Regional Public Health Network, and the lead organization here is a 501c3 that's had a very strong convening role in this region. They have a much budget at about $750,000, covering a population of 80,000, and they cover 16 municipalities and have 16 organizations. And you can see from here their degree of centralization is the lowest of all at 43.8, although they are still sitting there in the center of the network. There's a lot of connections across organizations in this region, and you can see that it's varied, that low centralization, that there's different organizations that are taking the lead and being most connected across the different health priority areas. Majority of their funding comes from the state. The other thing that we looked at was collaborative activity levels, which the tool measures them across a continuum of cooperative, coordinated, and integrated. And they going from kind of information exchange to working together that requires some planning and division of roles to working together that requires sharing of resources and power. And this shows how the collaborative activity levels across the regions, and it shows the Manchester and Monadnock. The blue is the integrated levels of collaboration. They all have there's a lot of collaborative activity happening out there at integrated level, but also at the coordinated level where organizations are planning and doing a lot of planning and sharing of some resources. And Patrick is going to look at these data as they back into the financial data for each one of the regions. And I'm going to turn it over to Patrick now. He can do that.
All right, thank you, Leah. Now, rather than bother trying to get control of the screen, whoever does have control, if you can just go to the next slide, that will help. All right, now this graph, what it does is it shows the relationship between density moving from left to right, population density, and then where you are on that collaboration scale. Higher means that you're more integrated, you're doing more things together, you're working tighter together. Now, Manchester, up in the upper right-hand corner, they have a large population density. They're like a city, or they are a city, and they're fairly high on that integration scale. In other words, all the different nodes in these networks are doing a lot together. Now, there's two reasons, and this is, again, this is a small study, but what we were looking for was things that are behaving the way we would expect them to. And this one was nice because, well, there's basically two reasons why you might expect that density to inspire higher degrees of integration. First of all, this kind of a clinical reason. In more densely populated areas, you just have more of those interpersonal interactions that are behind a lot of public health issues. And then second, the short travel distance, excuse me, between partners means that there's a lot of activities that are financially feasible to share. Distance might kill sharing activities in larger areas, but in tightly packed areas, you don't have to worry about that so much. So next slide, please. Now on the,
I'm sorry.
Next. That's okay. There you go. Perfect. Now this is the flip side of that. This one looks at just service area size, square miles moving right to left in the same vertical scale integration. So this shows that the more rural areas on the right-hand side, the more rural areas have lower degrees of integration. And again, as I noted on the previous slide, A lot of that might have to do with the fact that it's just not financially, it doesn't make financial sense to try and share certain services across greater distances. Next slide, please. There we go. All right, now this one looks at trust and revenue concentration. It takes a little bit of explaining, and for those of you who know me, it's driving me crazy that I can't point. Moving from left to right, revenue concentration, you are more concentrated on the right-hand side. So Manchester, way over there, Manchester has very few revenue sources, and they also are fairly low in the trust area. Monadnock, on the other extreme, on the right-hand side, they have a light concentration, and we're measuring concentration using a Herfindahl index of the number of funding sources. But Monadnock, on the left-hand side, they have lower concentration, which means they have more different funding sources, greater variety of funding sources, and they're fairly high in trust. So what we did is, so given this setup, and given that there was a pretty distinct shape to this, what we did is we said on the left-hand side, again, Monadnock, where there are lots of sources of revenue. Now, the organizations within these networks, they're probably used to getting together to divide these monies. In other words, there's lots of small transactions, and each one of these transactions is kind of an exercise in negotiating among the different parts of the network. So they have more experience working with each other on all these smaller grants. And better yet, because they are all, because of the number of funding sources, a lot of these transactions are smaller, so that you're not as vested in each one individually. In other words, you'll build up those negotiating skills at give and take, which helps build trust because you've got more of these different funding sources. And again, each funding source is a transaction for everyone in the network, an opportunity to figure out how we're going to split this money. Now, on the right-hand side, over by Manchester and Lakes, where there's not many funding sources, a lot of times what might happen is the nodes within these networks might be applying for the same grants. Everyone's applying for the same grants. And as researchers, we all know that, that when you're in a zero-sum game, sometimes there's, it gets a little frustrating, so that might inhibit trust in certain ways. Now, to use, now what this shows overall in terms of, more, sorry, I'm pointing. So back to the left-hand side where there's more sharing of monies, to use a relationship analogy, there's probably more trust when you've got a joint checking account. Now, going to the last slide, we have two different stories on the last slide, or at least my last slide. There we go. Whoops. There you go. Perfect. Thank you. Now, I'll do the upper one first. I'll do the lower one since we're talking about trust. Now, this one looks at salaries, the proportion of all spending that's going to salaries. Now, this is public health, so a lot of, a significant portion of all your spending does go to salaries and contracts. But you can see there's some variety going from about 50% all the way up to 90s. So as more of your spending goes towards salaries, you can actually see trust going down. Now, one of the reasons, this is an economic reason, one of the reasons that might be is as you spend more on salaries, in other words, moving from left to right, as you're spending more on salaries, you're spending less on all other resources. And that means that the resources become relatively scarcer, so there's more competition for those resources, which can inhibit trust. Now, let's switch on the upper side, looking at the black dots, which look at the impact of salaries or the interaction between salaries and the degree of collaboration. You can see the uphill slope, which means the more you're spending on salaries, the higher the level of integration you are. Now, it might seem a little bit weird because as you're spending a greater share of your total pocketbook on salaries, you'd think that you can start doing more specialization, that different, not only within not only within any one health institution, but across, especially as you're integrated, across the different ones. So you can have one of the nodes be specializing in lab services, another node does most of your inspections and so forth. So you can have that degree of specialization. And on the one hand, you'd think specialization means you don't need much trust because you don't interact that much. However, with specialization actually becomes more interaction, because if one person is kind of a jack of all trades, they don't actually have to interact with a lot of people to get a task done. But as you have lots of people doing a given task, breaking up that task into smaller places, into smaller pieces, there are more opportunities or more requirements for interaction just to get the one task done. So, like I said, they go in slightly opposite directions, and you might think it's a little bit strange, but it kind of does go to demonstrate that you actually can work together. Paradoxically, you can work together without trust, so maybe there is hope for my relationships. Economists are so romantic. So with that, I'll turn it back over.
Thank you, Patrick. So, in summary, we found we've got this decentralized system with wide variation across all dimensions, including the structure at the region level. But we did develop a mechanism to standardize revenue and spending streams. The study was small, obviously, for regions, so that's one limitation. But another limitation is that the network scores that we use reflect the scores for the entire network, so that the network scores among multiple partners. But the financial data reflect what's coming and moving out of the lead public health entity. So there's some possibility for incorporating in the future financial data partner network, and that we're in the process of validating with regions to finalize our data now. And the work that Patrick did provides some opportunity to do some kind of inductive research to maybe develop some hypotheses about connectivity funding source. So, I don't know, Joe, if you have anything that you would want to add out there?
Well, many thanks to the New Hampshire team, and Joe, if you need to jump in, go right ahead. But I'd like to open the floor. We've got time for one or two questions. I see there's a clarifying question on the chat box from Susan right now, who asks, is there a reference for the cooperation, coordination, integration scale that you used?
Yes, actually, that is the scale that's used by the partner tool, which was developed by Danielle Varda, who's out at the University of Colorado now, and they developed the scale. They had a whole process of developing that scale. It's been validated, and that's the scale that's used in through the. So it's
terrific. I see Joe is typing something, but in the meantime, does anyone else have any questions? Oh, she lost her audio, but she's here. So are there any other questions for the New Hampshire team? Gianfranco would like to know how we can get a copy of the slides. Lizette will be sending that out along with a recording of the meeting after the PBRN meeting closes. We do have an archive of all of our PBRN Research in Progress meetings on the website as well. It might take us a little bit to get a day or so to get them up, just because of the editing that needs to happen for audio and all of that, but we do try to get those up and updated as regularly as possible, but we also send out the links. Lizette, is there anything you'd care to add to that?
I think you got it.
All right, thank you. And Kara has just posted the link for the archives of PBRN webinars on the and Research in Progress webinars here on the chat box. All right. One more time around, are there any additional questions for the New Hampshire team?
This is Lee, and so Susan, is that Susan from New Jersey that's asked that question?
I'm not sure. We have a few Susans. We have Susan Zahner and a few other Susans. I'm not sure which Susan it is because there's no last name on the chat box.
It was Susan Zahner from Wisconsin. Sorry.
I thought it might be.
I can send you the references.
Excellent. Thank you so much.
Welcome.
Wonderful. And again, I'd like to thank our team from New Hampshire for a terrific presentation. This is really exciting work, and as are all of the delivery and cost studies, and we're getting to the stage right now where we're really beginning to see the fruits of those efforts. So thank you so much to New Hampshire, and we really appreciate the presentation. Just a reminder that before we move on in the program, that this is the last of the standalone PBRN monthly virtual meetings, the 90-minute calls that we've been doing almost since the inception of the PBRN program, I believe, which predates me by quite a bit. But we are transitioning the PBRN Research in Progress presentations to be part of the Research in Progress, the overall PHSSR Research in Progress series, and we will be advertising these much more widely. For this particular call, we actually do have a broadened audience because we have a number of mentored research scientists and other PHSSR grantees on this call for what's going to be the second half of the program, which we'll be getting to in just a moment. But first, we have a couple of updates that we need to make from the coordinating center side, and we have a couple of folks who are going to talk. First, we're going to ask Glenn Mays to talk, our fearless leader and director, to talk a little bit about a wonderful opportunity around RCTs. Glenn?
Sure. Thanks, Anna. Just we always like to keep folks apprised of funding opportunities that are relevant to your work, particularly your work in public health PBRNs. And one that we've talked about a bit over the last year or so has to do with the growing movement toward pragmatic trials and interest in supporting pragmatic randomized trials in real-world health and social service settings. One of the drivers behind that movement is the Coalition for Evidence-Based Policy that we've talked a little bit about in prior meetings. So they have just released their second round of funding, announced their second round of funding for to support low-cost randomized controlled trials that can drive effective social spending. So we want to call your attention to that opportunity. And again, we think that PBRNs are especially well positioned to think about how to incorporate pragmatic randomized trials into the kind of research they support with the network, because you do have multiple public health settings as part of your networks, and you can think about testing different innovations for organizing and financing and delivering services, testing them in some segments of your network and while using other segments of your network as kind of control conditions. So please take a look at that opportunity if you're interested in pragmatic randomized trials and testing those kind of designs in your setting. I will note again that we have at least one network, that our Kentucky network, that has already put a foot in the water with a pragmatic randomized trial using their one of our prior PBRN funding mechanisms. So take a look at that opportunity if you're interested. It'll be showcased in our newsletter that comes out, or you can. I've also got a funding page on my blog if you want. It's already up there on the blog if you want an easy way to click into that funding announcement. So just a quick heads up on that. And the only other thing I'll mention quickly is just again, we're in abstract season, so take a look at the many different opportunities for submitting abstracts for scientific meetings and professional meetings over this next year. I know Keeneland Conference just closed out, but you still got the NACCHO annual meeting, still looking for abstracts. You've got the Open Science, the Open Forum meeting for QI, and then PHI's meeting is still open. Academy Health annual research meeting is open for abstract submissions, and the interest group in PHSR. APHA just opened, et cetera, et cetera. So keep an eye out for those. Thanks, Anna.
Thanks, Glenn. And while we're talking about dissemination and translation, we've been involved in some exciting work with NNPHI around translation and building a translation toolkit. And we've asked Cynthia Lamberth of the Coordinating Center, who's been our chief liaison with that project, to come by and tell you all a little bit about it. Cynthia?
Thanks, Anna. As many of you know, we at the National Coordinating Center and our partners have directed and supported more than 100 applied research studies. And so in our goal to support our goal of rapidly transforming that research evidence into practical tools that our stakeholders in the public health system might use to inform and improve decisions, we're embarking on the development of this PHSSR Translational Toolbox initiative. So a competitive bid process was managed by NNPHI, which resulted in Health Resources in Action's selection as the vendor that's going to work on the development of the toolbox. So they'll be scanning this portfolio of work, looking for products and tools that are ready for translation. They'll be working with many of you that are on this call with all the research investigators and prospective research users to produce and disseminate those usable tools. So we wanted to let all of you know this project is underway. Valerie Paletta was unable to join us on the call today, but we do have Kristen Michalowski and Karen Schoenman from Health Resources in Action who joined this call today. They'll probably be on future calls with us as well. We will send out a formal announcement about the endeavor so that you know what we're trying to do and are aware that the effort is supported by the National Coordinating Center as the team from Health Resources in Action reach out to each of you. So, yeah, Kristen and Karen, if you wanted to say a quick hello, I suppose, but we just really wanted to let the group know that this is underway.
This is Karen Schoenman. I'll just say a very, very quick hello. I know Kristen is also on the line. You may very well be hearing her voice in phone calls in the future. Kristen, did you want to say hello?
Yes. Hi, everyone. We're really excited to learn more about your research.
So thanks, Anna. Back to you.
Thanks, Cynthia, and thanks, everyone. It's great to have you all on the call. These research and progress webinars are a big part of our push to get findings out to each other in the research community, as well as through the Research and Progress series to funders, policymakers, practitioners, basically any of our end users. So we really appreciate NNPHI and the Public Health Institutes partnering with us in this venture to try to create tools out of the tremendous amount of research that has already been done. And these folks will be contacting some of you in the future. And as Cynthia noted, we will be sending out a letter to more clearly and in a more detailed way provide you with some information about the initiative, and we're very excited about it. I did want to just point out that I have been linking for the last few minutes to some the other dissemination and translation resources, and I'll tell you why in just a second, because I'm sure that we talk on all of these calls about translation, about dissemination, about implementation, and folks sometimes wonder why it's so important. And the reason it's so important is because, as many of you know, we have anywhere from a 14 to 20 year gap between what we know and what we do in public health and in healthcare. We do not always do the best job historically of getting the evidence out into the places where it can make a difference. So this translational push is to really make sure that our PHSSR work and our PBRN work is having the optimal and maximum real-world impact on outcomes. So we really appreciate you all participating in these calls. We really appreciate you all participating in the Research and Progress calls. We appreciate your willingness to work with us as we move forward in this translational space. Which brings us to the next portion of the agenda, which is all about dissemination and implementation. As I mentioned earlier, we have some guests from the Mentored Research Development awardees who are going to tell us a little bit about recent experiences in that D&I space, particularly around conferences. I know some of you were able to attend the co-sponsored event, the national conference in Bethesda last week, co-sponsored by Academy Health and NIH. The good news is among those resources I put down the side of the chat box there is a link to the slides from that meeting. So just because you weren't able to attend that meeting doesn't mean that you can't access some of the slides from that. And as we hear from the folks who did attend, you may hear about specific sessions or things of interest that you might want to go check on there. So shortly we'll be hearing from Jackie McDonald-Gibson, Janine Harris, and Thad Miller. And time permitting, we'll have some questions and discussion at the end. But again, the science of dissemination and implementation is all about building the evidence for disseminating and translating the evidence, essentially ensuring that we are using evidence-based methods of sharing our findings and implementing our findings in the ways that are most effective. So that said, again, the resources are down the side of your chat box. We do have them also in a slide deck, but Adobe was being a little bit cantankerous this morning, so we weren't quite able to get them completely uploaded, but those resources will be in the PDF slide set that go on the archived website. So we invite you to, if you can't link to those from the chat box, then by all means check in the archived slide set shortly. We're going to be hearing a little bit more, as I said, about the Conference on the Science of Dissemination and Implementation. I don't want to steal anyone's thunder, but I will have to tell you that the health equity session, the D&I and health equity session there was one of the best plenary sessions I've attended at any conference ever. So I hope we hear something about that from some of our speakers. And with that said, I'm going to hand things off to Jackie McDonald-Gibson, and we'll hear her talk a little bit about the Society for Risk Analysis annual meeting that she attended just a bit ago. Jackie? Jackie, if you're speaking, you might be on mute.
Hello? Can you hear me?
There you are.
I was going to ask how I control the slides.
Jackie, you can back arrows on the bottom gray tab at the bottom. There's a forward and a back arrow. You see it on the left side?
On the left side, a forward and a back arrow. Huh. See. There we go. Perfect. Okay. See if it works now. Great. Okay. The format of these is a little different, so hopefully, okay, good. Right, so moving to the title page there, I'm going to give you a little bit of background about my research before I move on to talking about the conference that I attended and what I learned that might be relevant for dissemination of this research. My project looks at racial disparities in access to public water and sewer services in North Carolina. And the slides seem to just be going ahead without me pressing a button. There we go. Okay. I think I've worked it out now. Great. Well, why is this relevant to public health systems and services research, first of all? Because my background is really different from the background of most people on this call. Although I'm in a school of public health, my degrees are in civil and environmental engineering and also public policy. But if you look back at the history of public health, in fact, the first major public health organization in the United States was founded in Boston in 1869. It was the Massachusetts State Board of Health, and it was really begun to address waterborne disease risks. The risk that waterborne diseases were being transmitted through public water supplies. So there's really a very strong historic linkage between public health systems and environmental engineering, and some of that's really been lost, which is one of the reasons I'm really glad to be at the University of North Carolina. But anyway, we're allowed to kind of explore those linkages. But so my research is looking at racial disparities in access to public water and sewer service. And I think one of the reasons that most public health departments aren't so concerned with water service anymore, it's not one of the major missions these days in the U.S., is that there's a thought that these problems have really been solved. And I really argue that some communities have been left behind, and it's these that I'm looking at.
Jackie, I don't think you're advancing the slides. If you just want to let me know when to advance, I'll advance them for you.
Okay. Now, well, if you could go back one. Great.
I'm not sure what
No.
slide deck you're looking at, Jackie. We have your title slide with your photo on it is what's up on Adobe Connect right now.
That's really weird. Okay, so I'm seeing something different on my computer screen then. So it says background. And
Hold on just a minute.
Okay.
I think I'm gonna take the rights away from you so I can control it.
okay.
Because I think we're clicking on too many things. Okay.
All right, great. So the background to this is that now on my screen it's just advancing ahead.
I see the background minority communities were historically excluded from city services.
Okay.
Slide.
Very strange. My screen is not showing that. There are have been reports of minority communities that really are in geographic areas that should have been provided with municipal water and sewer service, but have been excluded from those services. And this is a remaining legacy of institutionalized segregation in the state. The magnitude of this problem is really not known, and so my project is all about trying to understand what the magnitude is, where are such communities, and what are the public health risks, what might be done to address these disparities. So the map that I'm showing on this slide shows one particular community about 20 miles from Chapel Hill where I live. It's called Mebane. And there's a lot going on here, but the key things to pay attention to are the locations of the green lines. Those are the lines where the sewers run. And then also the areas that are shaded in dark orange and lighter orange, those are the African American communities. And what you can notice is that the sewer lines run right up against the edges of these communities but don't extend into these. What's also interesting is that kind of in the middle towards the left, there's a little hexagon where the sewage treatment plant is located, and you'll notice that that's right next to an African American community, but again, no sewer service extending into that community. So this project got going because the state health director was concerned about these kinds of disparities, but really didn't know how big this problem is. So if you go to the next one, project objectives. Again, my project is designed to locate these communities that are on the fringes of cities and towns that don't have water service, characterize the health risks that they might face, because they're relying on backyard wells and septic systems, and the septic systems are often old and failing and in close proximity. Then identify what are the barriers to extending water services to these areas and how can barriers be overcome. So I'm not going to talk about the results. Instead, I'll just talk about, move right on ahead to what I learned from attending the Society for Risk Analysis annual conference. It was in Denver, December. So if you could go to the next slide. And I'm going to focus on lessons from one of the key sessions at the conference, both a plenary session and an entire morning agenda of presentations focused on fracking. Why is fracking relevant to what I'm looking at, other than the risk that it might present to people who are relying on domestic wells and don't have community water service? Well, really what I got out of this session is that this is a very politically charged issue, and because it's so politically charged, it's been really difficult for parties on different sides of the debate to have a rational discussion about what the risks are and ways to mitigate those risks. So if you look at the slide, there's one picture, a few weeks work, decades of energy. You know, this is really what the oil industry argues, that, well, we'll only be on site constructing wells in your community for a few weeks, and then there'll be just decades of energy produced afterwards. And then, of course, there's a lot of protest going on over fracking. You go on to the next slide. One of the plenary speakers was a really interesting woman. She's a professor of history at the University of Colorado, but she's been studying the political discourse over fracking. And what she's concluded is that what people need to do is to cut back on the shouting and take part in a civil discourse indicate by the consideration of evidence. So right now I'm on the slide that should be numbered 5, but it's called plenary speaker recommendations. I think the slide numbers got messed up when you all posted them, but plenary speaker recommendations.
Okay.
And she said that really what's going on is that there's so much polarization that people aren't listening to each other, and as a result, there's not a focus on what really might be the important concerns to worry about and an effort to go about addressing those most important risks. And if you go on to the next one that says, why is this relevant to water and sewer service disparities? What I've found, I've been going over to discussing this issue with some county health departments, and in Wake County in particular, where we've got some pretty detailed findings about disparity, at first people seemed very cooperative, and then I encountered incredible resistance. And I think that what is really triggering that is that nobody wants to be accused of being racist. So when I presented results to the Wake County Health Department, there's a group there that's in charge of overseeing private wells, and the people in that program got pretty angry and upset about the results. And as a result, what the private well people really kind of cut off communicating with me and said they really wouldn't be willing to work with me. So that was really too bad. At the same time, what I've encountered is that communities that are in this position of lacking water and sewer service and being excluded really distrust public officials. That's one of the reasons why these communities haven't come forward, except for a few exceptions, to demand services, because they're afraid that if they come forward to health authorities will come on site to their properties, inspect their wells and septic systems, and demand costly repairs. And in some cases, properties have been condemned when people. So if you go on to the next slide, possible research, dissemination, and translation strategy. I think that going forward, what I'd like to do is, make friends again with the people in the Wake County Health Department, but bring together a group of stakeholders, including community members, county health officials, the North Carolina Division of Public Health, which has been very receptive to this research, perhaps some local leaders, and have a discussion of these issues in kind of a neutral setting. I'm hoping that that might bring people together to begin to talk about solutions. So I'm planning to try to organize a session like this. Every year we have a conference here at the University of North Carolina on water microbiology. What I've been focusing mostly on is that some of these wells, a good portion, actually have high levels of indicators of microbial contamination. So if I can bring the county health department people in the room with affected citizens, said the state health department, which is open to this and requested the study in the first place, we might make a little bit more progress in kind of this. So that's really all I have to say. I think looking back, I think what took the county health department by surprise is that one of the deliverables for my Mentored Scientist Research Development Award grant was to publish an article in Frontiers in Public Health Systems and Services Research, and so I submitted that article about a year ago, and that was about a month after the county opened a new position of somebody to be like the private well czar in Wake County. I didn't know her at the time. I didn't send her the article for comment. And then when she found out about the article, she got miffed again, like seemed to think that it was implying that people in Wake County are actively racist. And so I think if I had to do it again, well, if I had known her at the time, I've learned it's good to run these things by people before they're published, not so you can change findings, but if there's any phrase that they're reading in a way that's other than what you intended, you can change the language a little bit.
Thank you so much, Jackie. Those are some really important lessons learned, and I think the stakeholder groups, particularly in environmental public health, are so many and so varied, and and sometimes you're really surprised at who challenges the work and who doesn't. And sometimes you're thinking, we're on the same team. We're really on the same team here, and the person who you really think you're advocating for thinks that perhaps you're not. So it's a great lesson to share, and I hope. Go ahead. Sorry.
Oh, I was going to say I apologize for the confusion with the slides. I have a
no
map.
worries.
Okay.
I think we just had an inadvertent slide share that happened, and I think what we've done now, hopefully we'll solve the problem. We've removed everyone but one host from the from the controls, so hopefully we'll be able to manage this going forward, because one of the exciting things about today's session is that we have a little bit of a multimedia element that we're getting ready to go into. One of our presenters is actually on an airplane and couldn't be here in person, so sent a video, and we're going to be moving to that in a moment. So for folks who have questions for Jackie, please hold on to those. We're going to first hear from Janine Harris by video, and then we're going to talk to Thad Miller and hear a little bit about his experiences in Bethesda. And we want to make sure that we hear the presentations first, and then we'll try to have time for a couple of questions at the end. I know Lizeth is in the process of transitioning now over to that video. It's going to take just a second for her slide share to work, and then I'm going to be quiet, and we'll let Janine take it away by video.
Hi, this is Janine Harris from Washington University in St. Louis, and this is my Teach Back session from the recent Dissemination and Implementation Conference hosted by Academy Health. Sorry I couldn't be with you there today. Our holiday travel started a little early this year. So the goal of my mentored research project was to begin building an evidence base for the use of social media by local health departments. In the first year, I started by examining the audience for local health departments on Twitter. I found that local health departments tend to be followed by other organizations rather than individuals. However, the organizations are not necessarily other health departments, but are from many sectors, including media, local businesses, other government agencies, and so on. With this article, I also learned to be more careful about the titles I write. While a provocative title gets attention, the media and others don't read too far beyond the title, at least in this case. So the media coverage of this work was not all that accurate. That was a big lesson for me. As an extension of understanding social media followership on Twitter, I also examined social media connections among health departments, since these might be natural pathways for dissemination. Here I found that local health departments tend to connect with other health departments that share some characteristics. So large health departments connect with other large health departments in the same state tend to connect with one another. This is a fairly common phenomenon in social networks. People and organizations tend to connect to others that share some characteristics. Generally speaking, through these first two studies, I found that health departments didn't have a whole lot of followers on social media. So I was interested in whether health departments were easy to find on Twitter. What was keeping people from following them? It turns out, as you might expect, that large health departments are pretty easy to find. However, I did learn that large or small, health departments with names that are comprised of words rather than acronyms are easier to find. So, for example, the Chicago Department of Public Health might use something like Healthy Chicago rather than CDPH if they want it to be easier to find for people in their jurisdictions. And then finally this year I've been examining how health departments use social media both to disseminate information in this e-cigarette Twitter campaign study and to do some surveillance in this study of how Twitter can be used to identify foodborne illness. It's been a really interesting project, and I'm aiming to use what I've learned as a foundation to help health departments implement and evaluate social media programming to address some of the essential services beyond even Essential Service 3, which is informing the public about health issues. So as you saw on the previous slide, one of the social media strategies I evaluated during my project was the use of social media to do better surveillance of foodborne illness. So currently I'm working on grant applications to implement this strategy in other health departments. So for me, at the DNA conference, the talk by Enola Proctor describing a checklist of 10 items that should be included in any application for funding an implementation project was the most useful talk of the meeting. An abbreviated version of the checklist she talked about is shown on the slide. For those of you who are interested, the paper shown on the slide includes the entire checklist and gives more details about each item. So if you start to look through this checklist, clear conceptual framework, detailed study methods, clear measurement, it seems like there's no way to cover all of these points thoroughly in short funding applications. So NOLA also provided some guidance about which to focus on first. So the most essential items are listed here in red, numbers 2, 5, and 7. First, number 2, providing enough background for the evidence-based program you're proposing is really one of the most essential things to do in a funding proposal. For me, this is a main challenge of my work. The evidence around the effectiveness of social media for public health is still emerging. So in my most recent funding application, I used one of the hybrid implementation effectiveness study designs from Jeff Curran's article. This is something that I would recommend those of you who are in emerging areas might want to check out. So Jeff Curran had a recent article. It describes 3 hybrid study designs that might be useful when the evidence is limited. So another essential item that ANOLA covered was being sure that the team assembled has enough experience and the right experience for the project. Demonstrating this could include evidence of team members having worked together in the past, if possible, co-authoring articles and grants. It should also include realistic estimates of effort by team members, since reviewers are likely to be familiar with limitations on faculty time, especially for faculty who are well known in an area. And finally, the last one, number 5, support and readiness of the setting to adopt your proposed intervention is key. And ANOLA suggested there that getting letters of support from the implementation site, which for me would be health departments, to demonstrate their support and readiness is one good strategy to meet that number 5 item. So the next tier of importance includes providing clear evidence of the gap between what's currently being done and the evidence-based practice you're proposing. ANOLA stressed that while this is really important, you should still limit the amount of background text that you use to meet this item, so you can provide more detail in the methods section. And finally, the last 2, number 3 and 8, the conceptual framework, theory, model, and study methods should be described in as much detail as possible and should include strategies for managing unforeseen change that might need to occur if the intervention cannot be adopted exactly as planned. So the known unknowns is what it was called throughout the meeting. For example, you might include a plan in the event of turnover in organization staff that are important to the project you're working on. So that's just a little detail on the implementation grant writing checklist, which I think was one of the main takeaway items from the conference for me. Again, I'd recommend reading the article in Implementation Science for more detail on the checklist items and some really good advice on funding for your implementation work. Thank you very much and happy holidays.
So that was, again, Janine Harris presenting a little bit on the implementation checklist, and that is going to be on the PDF slides that will be posted to the archive site on our website, on our PHSSR website shortly. And now, in the interest of time, we're going to jump straight in back on the conference on the science of dissemination and implementation. Thad?
All right. Well, thank you, Anna, and thanks all for the opportunity to say a few things. So I'm going to presume you guys are going to advance the slides, and I'll just talk a little bit. So to begin with, my mentored research scientist grant award has let me kind of tie up some loose ends that I have accrued over the years since I finished a dissertation in cooperation with CDC and local public health departments and others. We looked at the costs and the benefits of tuberculosis evaluation in the context of a lot of different projects that we're doing, and we looked at as thoroughly as we could the costs borne by society because of TB, the costs borne by health departments to control TB, the cost borne by individuals because they'd ever had TB. And when I say cost, I mean not only the economic cost of the goods and services consumed, but also the health losses. that were used. So you can advance to the next slide if you're advancing me. And so what we ended up doing was we got all of this cost data, all of this outcome data, all of this, very nice, nicely collected data over several years that had a lot of potential to be exploited and to be applied, but we didn't really have a project or an opportunity to apply it. I chipped away at it in my spare time, but my spare time has got constraints. Being a professor, they keep wanting me to teach. At the end of the day, I proposed and was allowed to, really take this information and build it into a nice model to look at. Well, so what are we getting for our efforts with TB control and so forth? And I did this in several ways, and I'm going to talk specifically about one and then relate it back to a session that I attended at the 7th Annual Conference for the Science of Dissemination and Implementation. I spent a good deal of time working with public health department partners, much like you guys are doing through your PBRNs and much like you guys are in your local public health departments. And we were asked to look at the return on investment for several different prevention activities in our state. So it's Texas, 26 million people. We're talking about big, huge money, big, huge effort, big investment of everything you can invest. And it was during the legislative cycle in which our Commissioner of Health, David Leahy, was going before the legislature and saying, well, what we do is vital and important, and here's why. He wanted evidence, and of course, this is very common and very important also. And so I worked, and we decided to look at tuberculosis as a case study because that was something I'd worked in for a long time, and I know those people very well at the state level, national level, and here locally also. So I launched into using all of this data that we had acquired to show what the state's efforts were resulting in. I built a big, extravagant, detailed model that works very, very well. I just built it in Excel because I'd set out to use Triage and some other commercial products, but it turns out they're fairly limited if you want to get into a very, very specialized project. And after many months of work and doing a lot of this work in Austin, directly with the folks in TB elimination in Austin, and then here locally in Tarrant County, which is Fort Worth, to vet our methods and how everything worked, and to make sure that we had included all the variables that were important and so forth. I had put together what an economist would really like, and as a pseudo health economist, I really liked it. I thought then, and I think now, it's probably the best purpose-built TB outcomes model that is available or has ever been made that I've seen anyway. I mean, maybe there's lots that I haven't seen. I'm sure there is. But I sat down and I reported out to the executive group at our state health department, led by the commissioner, and I basically said, what you guys are doing is great. It is valuable, and it is beneficial. It doesn't produce more money than it costs. Hardly anything does in health, and that was fine with everybody. But I also took pains to point out where there were efficiencies that could be captured. What we're doing is fantastic. It does what we want, which is to protect the population. But here are some ways that we could do it better. One of the important things that I pointed out was that a transition to an expensive new technology for the diagnosis of latent TB was was not something that could be supported on the basis of its value. I looked at the cost and the benefit of using these blood blood assays for latent TB, and I pointed out that even where they were free, so for instance, if a Medicaid program were paying for this, their value isn't sufficient to warrant their use relative to the old technology. And I was very happy with that because I'm a big proponent of spending my money more wisely. So I had the opportunity to step back into the conversation after a year with the Texas State TB controller, and I said, so, Sandra, fantastic, thanks so much for all your help looking at this. So tell me, did you guys, have you backed off on your adoption of this expensive new technology so that we could use that money for things that, actually are there's more of a value proposition for? And she said, oh, gosh, well, no, it turns out we haven't. We've doubled down on using these things. They really sort of accelerated the adoption of these tests. And of course, it turns out there are just lots of incentives that have nothing to do with value or clinical necessity that drive the use or non-use of all kinds of things. So we can skip to the next slide now. I don't have very much time, but I will say I had a great interest in attending and did attend a roundtable about de-implementing unnecessary services because I found, look, good credible evidence that was arrived at in cooperation with partners who have a vested interest in being efficient and doing the right thing isn't the only, well, wasn't effective in this case to de-implement what I believe and I think is beginning to be understood to be probably something that needs to be de-implemented. This is important. What not to do is important to know. It's as important as knowing what to do. And so my lessons are that incentives matter and that people who are empowered to make local decisions probably have a lot more ability to do the right thing at their level than we do from a big 30,000-foot level. And in our case, they had large contracts. They had shifted over and transitioned their laboratory services to be able to accommodate these things. And so one of the things that we ended up doing was we took my big, gory model that is complicated and hard to use and easy to misinterpret and everything else, and we built it into a what right now is a beta version, and we can skip to the next slide, by the way, what now is a beta version of an online open access hosted tool which anybody can log into and can see for themselves, should I do this or should I do that? Should I do this or should I do that? If I do this, what will it cost me? If I do that, what will I gain? I have taken the approach to sort of micro scale our decision making to the individual level so that individual practitioners, individual clinicians, individual TB controllers can see for themselves what the opportunities are and what the costs are for doing one thing relative to another, and to do it in such a way that it is not hard to interpret and that it doesn't take an expert and it doesn't take a consultant or anything. So with that, I look forward to answering your questions when we enter that period, and thanks very much again.
Thanks so much, Thad. It's really been interesting to hear from Jackie and Janine and Thad about their different experiences with dissemination and implementation, or in Thad's case, de-implementation. I have once again pasted the link to the slides from the Science of Dissemination and Implementation Conference at the very bottom of the chat box, because I know there were a lot of links there, and I want to make sure you all don't miss that one. Again, I thought by far the star session for me was health equity, but I do a lot of community-based participatory research, so that would be why I thought that one. But I recommend that you all have a look at those slides as you have an opportunity. We are at time, but if anyone has one burning question for Thad or Jackie, I'll go ahead and open the floor for that. Are there any burning questions? All right. Hearing none, if you think of any, you can shoot an email to them directly or to the coordinating center, and we'll make sure they get it and they can touch base with you. Here is our public health PBRN email address. And again, I want to, since this is the last of these PBRN calls, I want to thank Lizeth Fowler for doing such a terrific job of herding cats for the last 2 years in making these PBRN webinars happen. And I want to thank Ann Kelly as well for all the work that she did in programming the second half of this call and getting our mentored research scientists on the line here. So thank you guys so much. If we don't talk to you before then, have a happy holiday break. Take care of yourselves, and we'll talk soon. Thanks so much. Bye-bye.